All right. Okay, so we're going to dive in and we are going to start with Enbal. So let's start with the big question, the impact of surveillance on understanding and outcomes. So who's doing the surveilling right now, and how is that surveillance impacting your research in particular?
It's a great question. I think the surveilling of what is probably the good follow-up question before I start answering. I think we have so much data that is available at this point that we hadn't previously used for public health or healthcare decision-making before. So when we are thinking about the surveilling, we are thinking that our smartphones are collecting data on us all the time. And historically, that has been commercialized and only sitting in business settings. Some of those companies have started sharing those data in an anonymized, so anonymized smartphone data have been shared with academic institutions in some instances. And so we've been using some of those data to help respond to concentrate understanding in our region, specifically looking at how stay-at-home policies have been have influenced mobility, so residential mobility. So the residents in each community, how are they moving around the community, and when they leave home, are they leaving home for work, what type of work, and then we were able to collate that with other types of work. So the surveilling is happening primarily by commercial entities, and sometimes are being used by public health researchers or medical researchers in general. And then hopefully we're sharing those data with decision makers and people who are trying to be prepared for patients coming into care, or identifying locations where infections need to be, or testing needs to happen for certain populations in that by location though.
And that sharing of data is new and particular to COVID.
Yes, absolutely. So we are, right, none of this has happened before. This type of pandemic hasn't really happened at the same moment that we have so much more technology that is able to help us inform what we're doing in real time. So, I mean, I could show you a couple slides of how we're using that. That would be great.
Yes.
Let me show you. Every time I delay, I practice it, and then it's not as fast. Okay. So this is in general, you've seen these types of maps. If you're on and you are not in St. Louis City and County, then you might not know about our St. Louis region. Our concentrated cases are in the St. Louis City, North St. Louis City and County. And we have hotspots, and we've identified those hotspots geospatially and identified how, what we wanted to know is, this is data from zip code level data from our health department. So we started looking at that anonymized smartphone data that is available. And so we were able to say, are people staying home, is there a larger proportion of people staying home each day increasing over our stay-at-home policies. So what we're seeing, and these are the zip codes associated with those two counties, we're seeing that there are patterns of increase that are significant, that people are staying home and by their zip code. And then there are outlying zip codes. So we're able to say what's going on in those zip codes that are helping us, or that could help identify public health and healthcare needs related to COVID infections. And ultimately, still people, there are still more people staying at home than not staying at home, because there's a lot of talk about people are leaving their homes and a lot of that sort of thing. So what we are finding, that still 6 weeks in, people are still staying at home more often than not, and significantly more than at week 0, which is when we the stay-at-home, the week before stay-at-home policies started in our region. So what we wanted to know ultimately was, why are people leaving? So that anonymized smartphone data was allowing us to identify the full-time work and part-time work. And those concentrations are in the same locations or really similar locations to where the infections are as well. So the North St. Louis City and County, we have hotspots of people leaving for work, and we're saying, okay, so what kind of work are they having? Ultimately, we collated this data with other pieces of data that helped us inform they're essential workers. There are essential workers. So the food service employment have higher concentrations in North St. Louis City and County, and we identified that people who are traveling farther for work are at higher risk of leaving their homes and collectively at higher risk for COVID infections. The same for health support employment. So this is our residential facilities, our staff that work at residential facilities and the like. And the food service employment was really about grocery stores. So when we look at those concentrations, we're finding that is especially our populations at risk. So we know this, right? But we don't consider what are the policies. We're hoping that some of this, sharing these these data with policymakers, how can we change some of that? How do we help employers identify how important paid leave is, paid sick leave, so that they're able to stay home when they're sick, or to identify symptoms. So is an essential employee really experiencing symptoms? They may not be experiencing symptoms, but we need to know where they're going, and we need to know where else they might be going. So they might leave for work for 6 miles away and come back home in their home community and bring the infection there. So that's really ultimately a translation into contact tracing. And so contact tracing in general is looking at how technology or contact tracing traditionally is asking people to talk about where they've been, who they've been near, and then having to recall all of those people and places and numbers of people that they may be in contact with throughout every day or a certain set of time. With COVID-19, that's really 2 weeks of time. And so if we were able to leverage technology-based applications, we in the United States, we're not that comfortable with using these. It's basically an app-based tracking self-reported symptoms, the who and the where of individuals of symptoms or positive cases. And so it can help identify, really pinpoint where infection's happening more easily for public health agencies to come in and help those pieces and really start doing more pinpointed testing needs. We have at St. Louis University, we developed My COVID-19 Tracker. We are one of many that have developed these types of apps, that including Apple, Google, MIT, and SLU. And so the crux of that is my colleague, Dr. Rozier, is going to speak on, is really the challenges of getting people to use it.
Got it. So, yes, and getting people to use it. I know there are other countries where it's not a choice. Can you talk about that a little bit, and the threshold of, if it's not a choice, how do we get enough people to choose that it actually makes an impact?
Yeah, I think in general, I think the latest average for countries that were not requiring tracking and downloading an app, the usage is around 30%, 40% for people who generally are trying to, governments or organizations that are trying to encourage people to use this. I think the challenge is India just opened up, and they are requiring people before they get on a train, they have to download the app, which is thinking about how you reconstitute what we do as in our normal routines is overwhelming. And I think we're struggling through how do businesses open up. It's just a push and pull. And I think that who gets to have the data and who gets to see the data is one of our significant challenges.
Yeah, absolutely. So my last question for you, and then we'll move on to Michael. you're getting this data for the first time and you're analyzing it and being able to sort of marry it with other data sets, is it making a positive impact on public health in the community?
I think so. I certainly hope so. I've been I've been doing a lot of data sharing and a lot of analyses, quickly sharing with different organizations, and both with our healthcare executives as well as our public health agencies. And so they appreciate the support. I think that it's complementing the efforts that they are implementing, and so figuring out how to best continually update and to benefit their practice and inform their practice is really the ultimate goal of this type of work.
Absolutely. Okay. And so moving on, Michael, I know you do work around privacy and data sharing and people's perceptions. I think I'd like to start with the big question of, is privacy a human right? And is it negotiable based on circumstance? These are unprecedented circumstances.
Mm-hmm. Yeah. So generally speaking, I think there's consensus that privacy would be a human right among many. And the key is that it is generally not considered an absolute right. And so we have certain things that would be absolute rights, that no condition, no situation can kind of derogate that right. So freedom from torture would be one of them. Freedom of conscience or freedom of thought would be another one. Like there's no conditions under which it's acceptable for that right not to be met. Privacy is not one of them. And so we have situations classically in the United States, even public health emergencies are one of those situations where the typical right to privacy is somewhat modified to achieve other important objectives. Now, of course, the big question then is to what degree and what other goods or objectives should be used or can kind of counterbalance that right to privacy. And my general position on it is that we try to negotiate that in the public square. That is where policy, discourse, all of the kind of public conversations that we're having is necessary to figure out where that line is, because there's no formula, there's no kind of cost-benefit analysis. We need the public to actually buy in to what we are trying to achieve in order for it to have not only kind of to be ethically justifiable, but in public health, our general position in terms of ethics is that if an intervention doesn't work, it's not ethical. And so, like, we don't want to waste people's time, resources, etc. if something's not going to work, because that in itself is unethical. And so, for me, a big factor is can this actually be shown to work effectively to diminish the spread of the disease? And in order for that to occur, the public has to largely buy into it.
So what are you finding so far in your research on public buy-in, and is it changing because of the pandemic?
Yeah, absolutely. So we're seeing a couple surveys come out. Actually, Dr. Shacham and another professor in the College for Public Health and Social Justice and I launched a survey. We're planning on doing it the first or second week of March, and this was not connected to COVID whatsoever. And it was all about kind of location data. And as you mentioned in my introduction, my research is really on kind of self-identity and the way that our data shapes who we think we are. And all of a sudden, this pandemic became conversation. So we dropped in some COVID-related questions for location and privacy. And so displaying just a couple of the results from this survey on the screen now. Generally speaking, we asked, what entity would you trust to have your location connected data? And we found that across the board, people trusted government more than they trusted private entities, their neighbors, organizations like schools and gyms and those kind of things. So there was a general kind of over 70% of the population trusted government. And the interesting thing, so we expected there to be some kind of difference around age, political ideology, income or education, and we found no statistically significant differences across any of the major demographic groups. Now, I think one thing to keep in mind is that this was the second week of March, 12 to 14. People were aware of the epidemic, but at that point in time, the epidemic had become less politicized. So this is before wearing a face mask in public was a political statement, or this was before there were so it would be, I think, interesting to see whether there are now kind of more politically divisive elements of disclosure of information. But we found early on in the epidemic curve that was not the case. We also found that there was a gradation between when people were wanting to disclose information and when they weren't. And people were far more willing to disclose their own information and want other people to disclose their information when they were diagnosed with COVID, as opposed to just kind of generally gathering information about everybody and disclosing that. And so it shows that people are being reasonable and thoughtful about what would justify this kind of invasion of privacy. And people generally think that there are justifications for different levels of privacy to be established.
Wow. And we had an interesting question from the audience, which is, I think, worth talking about now. Someone asked, when we say we need the public to agree, who's the public? What does that mean to you all?
So I can answer that, or maybe if Jason or Enbal have some initial thoughts.
You can start, Michael.
Okay. Yeah, so I think it is important to say that something being held by the majority of a public, of the public as to be true does not mean that it is ethical. We do not need to look all that far across history to understand that public opinion is not the same as being ethical. And so we rely, I think, on leaders. And if this crisis has taught us anything, it is that the leadership or the absence of leadership is actually a very ethical enterprise. And I would say that generally speaking, we count on the political and civil, so civic leaders, whether it be business or nonprofit or whatever, to really kind of help shape the conversation around not only what is possible, but what is ethical.
Great. And then Jason, we'll move on to you in a moment. Michael, I have one more question for you, and that's around consent. Is there an ideal way to request consent, and how do we ensure that what we as consumers or users of these technologies are consenting to is really understood, and is it durable? I think that's a big one for all of us who, kind of read about how our data has been shared with organizations through Facebook, for example. We're wary.
Absolutely. So most of our kind of thinking around consent comes from human subject research. That is certainly where most of the kind of work has been done. And I've put up here the kind of general criteria that we try to meet when engaging in human subject research to make sure that informed consent is met. What we're talking about in this situation, though, especially with the kind of technology that Dr. Shacham was talking about earlier, is that there's a degree to which we don't always know how we are going to end up using the data that we collect. So that's one piece of it. So how can I be informed as to whether I want to give the data away to my public health department or to a hospital when they don't necessarily know all the things that they're going to need to do with it, like gathering the employment information that Dr. Shacham shared. Like, we didn't know that we were going to need to use that for this particular purpose right now. We do. So how do we have that embedded into the consent process? One of the ways that we try to do it, especially at the population level, which is another thing that's different than traditional human subject research where one person can consent to what you're going to do to me. We're talking about population level consenting processes, which we also have some experience with in the health sciences. And some of the best strategies for that is to have kind of public representatives who serve as the watchdogs for what is being done with this data and can call to account and can keep the entities that have this data accountable for the proper use of that data. So, so there would be a couple elements how consent would need to be modified for something like this. The other piece that I think is really important, that's kind of harkening back to some of the data that we saw earlier, is it's one thing to consent to a particular process, but we need to keep in mind the way that any intervention is when it needs to be terminated, basically. And so what justifies stopping using this data? And it can happen in a couple different ways, in my opinion. One is could be that the threat is over and therefore we don't need to use it. The other one thing that we might see is that collecting and using this data is actually, it could exacerbate inequities that already exist in our community. And so how do we make sure that the data that we're collecting are actually reducing inequities rather than, like, you could imagine being able to track somebody who is violating quarantine, and the people who need to violate quarantine are the people who don't have the supportive resources to do it well. And so there you would just need to make sure, okay, people might consent to this, we might want to do it as a public, but we cannot have an unequal kind of process for being able to meet the thresholds that we're asking people to do as a public.
Wow, big stuff. So, Jason, moving on to you. Now, you're actually an MD, you're a practicing physician. I know you're treating patients on a weekly basis through this pandemic. I would love for you to talk about, like, the short-term need versus long-term implications of, the informed consent, and what are the long-term implications of the decisions we're making today as a community?
Sure. Cindy, thank you so much. I want to start out with the thought that, anyone who uses Google or Apple right now has negotiated away a ton of their privacy, right? I mean, it's already a foregone thing. And so I wonder if, we could talk about, the current set point, for privacy is, I want to think about, have we reached a new set point in this kind of crisis era of COVID, right? So I don't want to die, so I'm going to release as much of my data as I possibly can right now to the powers that be, and it's right maybe to do so in a crisis moment, but we have to absolutely make sure, that this doesn't trickle over into other parts of our society, and we need to absolutely scale back at the right time too. So I think the question of, are we even going to be able to scale back is a great question to ask. When the COVID curve has curved, are we going to be able to come away from this kind of very big surveillance that we're doing? We should also be really careful about, who is doing, I want to attend to who is doing the surveilling, so, right. So we have this Apple and Google partnership, right, that that has come about, and it brings to mind the idea that are they going to do this right? They are, of course, for-profit corporations. Do they have a duty to do this? And if they have a duty to do it, what would that duty be? They're like the singularly best positioned companies, right, or people to be doing something like electronic surveillance, but they might not be the singularly best positioned people to scale back and give people back some privacy. They're not essentially democracies. What I when we, in our preliminary discussions, what I really think is we have to do the surveillance in the context of democracy. If we leave it to for-profit corporations, we remember Milton Friedman, who said the social responsibility of a company is to make a profit. That's true. I think it continues to be true in the 21st century. And like Michael said, this data is going to exist forever, right? And technology will continue to improve and change, right? And who knows what the future value of the contemporary data might even be. So I think once there's a revenue stream attached to it, it's hard to let go of that data. So I think that long-term consequence is going to play out that way, potentially. And we have to be careful about that.
Absolutely. So we've got some great questions coming in from the audience. Dave, do you want to, I see one here that's really pertinent to Jason's remarks. Do you want to?
Sure, yeah. So Brian Joyner is asking essentially about the terms and conditions, right? So we've given up a lot of privacy, but a lot of people don't understand that, right? So do companies like Google and Facebook owe us a simpler agreement, a simpler set of T's and C's, terms and conditions? Is there opportunity? Can we simplify that rather than just scroll through the endless text and click accept and get on with our lives? Like, how could that be better?
That is a great question. I think that we could ask such companies to do that, but we cannot hold them to it. I mean, how would we hold them to it? We would just say, I'm not using Facebook anymore. That's not happening. So, right, it's sort of incumbent on our politicians. I think it's incumbent upon municipal leaders, governments, to require this sort of thing, of course.
I'm interested in hearing from all of you on the public-private partnership, and historically, with regard to health outcomes, do corporations like Apple and Google and academic institutions or research institutions, do they make good bedfellows? Are there good examples and bad examples we should be aware of? Sorry. Let's see. Jason, I'm putting you on the spot.
Yeah. I mean, they make great bedfellows in the sense that the good here is obvious, right? I mean, we've bent the curve to a certain extent. We have all this data coming in to people like Enbal and Michael, right? It's working. Just wanted to reiterate, kind of what I was talking about before, though, that there's this risk that we're doing it not in a democratic way. I mean, it's like the contact tracing, right, is not being done by us, really. And so I think that, I kind of feel strongly, I've written about, like, if you're, if you're one group and you're surveilling another group, it depends on the kind of the power relationships between those groups, but it resembles a certain type of colonialism, right? You're getting something of value. So what's the thing of value for Google, right? What does it thrive on? It thrives on people's data and their information, what they think and what they search for, where they are, all those things. That's the commodity. And I'm thinking, it can be pretty exploitative. On the other hand, it was a solution. Not to be too negative, that we need to shore up our democracy, right? I mean, this is our moment. You know what I mean? This is our time to enrich our democracy in a sense that can handle this problem.
It makes me think of like very simple forms when you send your child to a new camp, they have a questionnaire that says, are you willing to share, are you willing to allow us to take photos of your child? Yes or no? Are you willing, if yes, are you willing to allow us to share those on promotional printed materials? Yes or no? Are you willing to allow them to share in social media? Like, it is a series of yes, no's versus
Right.
Apple and Google and Facebook, where it's 48 pages, all in or all out.
Right.
There should be gradations.
There should be gradations. I just want to add to one of Jason's points about the terms and conditions. I think one of the challenges that we have is not only, this is relying, we can't rely on the corporations to make those decisions on saving our democracy, really. But I think we can have something that is more aligned with what Cindy just highlighted. You're either all in or you're all out, but you can't actually, to function in our world these days, it's really hard to not have a smartphone. So if you say, I say no, you don't have those choices, right? And you don't have that resource either. And so you think about the haves and the have-nots, you don't have resources. We've already talked about access to the internet, and we've had highlights of people are accessing the internet through smartphones. We've kind of circumvented the needs of building a better internet infrastructure in some ways because of that. And so I think back to how public health has operationalized many laws, and we've made and influenced laws related to car safety, seatbelt use, even drinking under the influence. There's a limit that's associated to some public health guideline. And so we've really, some people might consider that overstepping, but the other point has been there's a cost associated if you don't do that. You can think about smoking bans. It's the same idea. The public smoking bans is the secondary health effects of people around people who are smoking. And so what are there potential pieces that we could say you're sharing data that's harmful to our humanity? And it's a big leap. I mean, it is a leap because we limit the stretch of these public health rulings because of our freedom to behave in however we will.
Yeah, I really appreciate this conversation, and for me, it comes down to can we have shared goals and objectives? Can we have maybe business and government, business and society have maybe not shared goals, but not mutually exclusive goals? The thing about the public health examples is that it was very clear that those things would reduce morbidity and mortality. And so the public health argument for this kind of stuff would have to be something around, some public health objective. And so we might be able to make a mental health argument around something like this. I don't know. But the question in my mind, okay, so what is the goal or objective that we are putting forward to the public, saying this will allow us to achieve this common objective that we can all buy into? And I just don't know if we're there yet. The other piece that I think that's unanswered in this, I think it's answered in this question in this country differently than it's answered in places like Europe, is that who owns the data? we do not have a sense in this country that I own data that is generated by me. And that doesn't have to be the case. That is the case. But if we wanted to have some kind of different position, that would require a robust, again, public conversation in the same way that Europe recently has done around private ownership of data and being able to see what data companies possess, being able to delete that data if necessary. We don't have that sense in this country.
Gosh, I mean, ownership is such an interesting idea in and of itself, right? Like there are a lot of countries that don't even have like property ownership. Like they don't have the administrative capabilities to like have a deed for a plot of land that everyone knows is exactly right here. And so like we've got that handled in the United States pretty well. And then you keep abstracting and going layers and layers deeper. And now it's like, oh, the data ownership, like, can we go back to the way that the Native Americans lived where they're, everyone owned everything? Like, is that a thing? Like, I think that as far as like, when we talked earlier about how do you define what ethics is based on the majority, and we say, okay, well, it can't just be like mob rules, majority rules. Like you have to think about what are business leaders thinking and what are civic leaders thinking, and kind of like triangulate a middle section, like this is the platform, and it's not a fixed point. It's like a contour because different people have different needs and there's all these different perspectives, and you kind of like merge in on that. We talk a whole lot at Prepare.Ai about data and technology, and I think that it's really important to think when you're defining that decision boundary, that contour of like, here's where we should go, and we should go no further with data, and in this context we can go a little further, but in this other context we need to hold it back. I just think you can build that contour so much better when you have data, when you have the voices, when you have the government mandates and the votes and the regulations. They outline very clearly, like, here's a boundary that is the lowest common denominator. But then people vote with their dollars, and they vote with their likes and their unsubscribes, and they, we need all of those data streams to kind of fill out the tapestry of what does that decision boundary look like. And I'm not a medical ethicist. I'm not trained in HIPAA and medicine and healthcare and public health. But outside looking in, I'm a technologist, and I say, like, we need to loosen the standards for HIPAA and get the data flowing. I mean, that's just my point of view. I don't know. I think that we could do well to get, to loosen the restrictions on data movement in some healthcare applications rather than tighten. And maybe in social media, it's the opposite. We need to tighten the data sharing restrictions there rather than loosen. Well, so these are some of the ideas that are coming in on the questions here. So we have an interesting question. How do you, when we're talking about defining that decision boundary, what is ethical? Can you trust business leaders if their first loyalty is to the goals of the business? Can we? How do you include that into the conversation when you know that the profits and the shareholders are maybe their first loyalty?
I love that question. That is such a good question. I mean, it's going back to Milton Friedman. The social responsibility of a company is to make a profit, right? You have shareholders, and I think the issue of trust. I mean, I wonder if the question is the thing you're after is it trust, or do shareholders have to demand these things out of these companies? I mean, that's really the way I see it happening, and they're not, right? I mean, why is that? That could be a question. I don't know the answer, but that's the way I see the relationship. What do you think?
Yeah, I mean, I think, maybe there's clogged places where information can't move because there's cronyism or there's incumbent, like the decisions of a corporation are going to flow in the same paths if you don't dig out new places for it to go. And a lot of those paths are very entrenched, like who gets on the board seat, and how much money is going to be given out as dividends versus paid to executive, bonuses. So some of those decisions, they just keep you going on the same glide path, and you really need a loud voice of, Occupy Wall Street, or, protesting to kind of like jar a company from that path, or like a lawsuit, a class action lawsuit. I think there's places for all of these voices to, move businesses back and forth. I guess, I don't know, maybe some are, more effective than, certainly some are more effective than others. Should we be doing more of one or less of one? I don't know.
I also think so that the skepticism that we might have around business leaders because of the profit-driven nature of that, I think is good to keep in mind, and ought not lead us to exclude their voice from the table.
Totally.
They're too important to our society, and I would much rather have those voices around the table and help shape the understanding of what they're about than exclude them and treat them as objects of regulation, merely as objects of regulation. And one of the reasons that I think it's possible, getting back to this idea of trust or accountability in the public, like we see on a very regular basis that people still have a strong sense of what's right and what's wrong. So in this space of HIPAA kind of data, et cetera, when there was information that University of Chicago and Mayo and Ascension were trading Project Nightingale with Google, and that there was public outcry. Now, whatever your position on kind of intricacies of that is, people had a kind of inbuilt sense of what's right and what's wrong, and that's still there, and we can hold companies accountable based on that. And so just kind of two quick things: that absolutely we need them at the table, and we need to trust our kind of public instincts around what's acceptable, because I think they're still there.
And I would add that in the context of COVID-19, my observation was that the technology companies were at the forefront of raising the alarm, making sure that their employees were safe from the standpoint of travel and working from home. And I thought that they were much quicker to respond to the threat than other organizations. Now that may be because they had the data, so they were more aware of what was going on sooner. But and I am a technologist like Dave, I was appreciative of the fact that some of the big, huge companies were out publicly stating this is a real thing. We all need to start worrying about the greater good.
I think technology companies move quicker in general. I agree with you that they were on the forefront, but I love my institution. I love my place where I work so much, but they are not fast.
So we've got another really interesting question from Pradeep Das. Since data analytics tools like AI reside typically only in institutions, how do individuals explore and analyze data for long-term trends for their personal interests, such as capabilities building?
I think that goes back to, I guess my concern is who gets to have what data, right? So in the sense of the commercial companies that's sharing anonymized smartphone data, we can feel good in general, at an academic institution with a research aim and a goal can say, I propose to use these data in this way, and I won't use it in other ways, I promise, is what we did, right? So I think when we think about everyone having access to these data, what does that look like? It goes back to that really good question of who owns those data? Who do you share it with? I think in that combination of, you know, HIPAA related data versus general my movement patterns, all of those things answer bigger questions if we can collate those data. Yeah, that was my initial thought to hearing that. I was like, so how would I give you as an individual those data? Do I feel good about it? It makes me a little nervous. But
And,
maybe yeah.
And going back to the idea of consent, you can ask for consent when you have a limited or a very narrow kind of appreciation of what you are going to be doing with it. As soon as you make that data publicly available, that whatever consent process you brought somebody through goes out the window essentially, because you have no control then over who's doing what with that data. So you could have broad consent and say, we will make this data publicly available. Are you okay with that?
Mm-hmm.
Then that's appropriate. But if you actually want to tell people what you're doing with it, then you have to hold it close.
And it decommodifies the data, right? When you make it open source, it's not worth anything anymore. And that's the fundamental feature of Google.
I mean, that's not great either, right? So
right.
I think I think COVID is a great example of how much more we can do together. And I still see pockets of people holding their data close, right? Oh, this is my data. And to me, it's like, let's share it, but knowing there's commodity with data, there are promotions with data, there's money to be made with data.
Yeah.
So I have a question for the panelists. Can you describe, just like to level set for us, right? What are we talking about here? What is a best case and what is a worst case? When we're sharing this data, if it's unethical and things go super sideways, what is a worst case scenario? Maybe one or two of those. And then the opposite, like, why are we doing this in the first place? What are the good cases? What would be a good outcome?
So for me, one worst case scenario is if your medical condition is disclosed publicly and can be used against you, either in terms of employment, social status. Like, fortunately, COVID isn't stigmatized yet. I could absolutely see it being stigmatized in the same way that we know a lot of other diseases are. So that would be, I think, maybe not a worst case, but a bad case situation of using these data. I'm good with worst case. Who wants to do a best case?
I'm just going to add to Dr. Rozier's point. I actually think there are pockets of individuals and populations that are finding that COVID is stigmatizing, in that the cost of getting tested is worse, because if they find out they're positive, they can't go to work. And that cost is significant in their community or in their family, because they can't get income, they can't get childcare, and all of those pieces are exacerbated. And so I think there's a piece of the concern with data. Maybe this is another worst case scenario. Sorry. Misusing the data and really describing a population or a region that talks about, well, these people don't stay home, right? These types of people are not adhering to the stay-at-home policies. And so then when you see them out in public, what does that translate into? I think that's an unintended consequence, but it's also an uninformed consequence. It's like, yeah, I might live there, I might not be able to stay home because I'm an essential worker, not in the way that you have characterized essential workers as doctors and nurses, but rather as your Instacart worker. You're fine to send an Instacart worker, but not yourself going into that grocery store. So thinking about how we operationalize who gets the data, what do they do with those data, and how does that translate into like social protection services? The costs of social protection should be at the forefront when we're talking about COVID.
Yeah, that's interesting. It's kind of like a right to work, right? Like is it ethical to test people if are you gonna oppressively make them not work and earn a living? That's really interesting.
Yeah.
So I'll answer the other part. Best case scenario, we have limited usage. It's an effective public health intervention. We're able to rapidly contact people who might be exposed, test them, have them supportively isolated, and we just wipe this COVID-19 out of our communies.
Yeah.
That's
Done.
best case.
We might trip over ourselves, but that is going to happen.
That is what we're going for. All right, we have 1 minute to spare. I want to be respectful of everyone's time, but I would love to ask one final question of all of you. What is the one thing you would ask of our audience that they can do to make our community safer?
I'll go first. You know, in this country, we have this incredible blend of expertise, insanely good expertise, and skepticism, right? So everyone in the audience needs to collectively find that wisdom to find their way between skepticism and trust the experts.
Nice, that's a good one.
I would say as we start reaching this situation where people are going to want to be creeping out more, kind of less social distancing, less kind of quarantine, to do everything you can to support the people who want to continue to do that. And so whether that's an additional call or, you know, whatever, yeah, do whatever we can to continue to support each other through these moments when we are going to be tempted to edge out of this.
It's a great one.
Yeah, I think the other piece I would add is really thinking about when you do go out, who are you going to be exposing? It might not be you. You might not feel like you're especially at risk. You're going to you may be carrying coronavirus to somebody else. And who are all those people? It's hard to imagine what that looks like. That's a giant network of people that you do and don't know. And so thinking about how we take care of our most vulnerable is really what I want us to consider continuing. So thinking about masks, continuing to use masks, and then being really patient and trusting our experts.
That's great.
That's a great ending.
Yeah.
All right. Well, thank you all so much for your time today. I know how busy all of you are, and we're just so grateful. And the community is grateful that you're willing to share your thoughts and ideas and expertise. We're going to keep asking you to go to the front lines and do this work because we all need to stick together and stay safe. So
Thank you very much.
very grateful.
Thank you for the opportunity.
Thank you for hosting us.
It's really great.
Absolutely. Thanks for everyone who joined us. We really appreciate it. We hope to see you all again in 3 weeks. Take care. Bye-bye.
Care.
Bye.